Okay, let's start, and I'm sure others will join in as we go. So welcome everybody to yet another wonderful Spotlight on Stigma webinar, and together with Eleanor Karma from the Centre for Social Research and Health, we run these webinars 4 times a year to bring great perspectives from research and from lived experience to understand the range of different aspects of stigma that we might be working for. My name's Carla Treloar, and I'm joining today from Bidjigal lands, and I pay respects to elders past and present and acknowledge the traditional custodians of these beautiful lands. I just went for a bike ride this morning around the shores of Kame Botany Bay and reminded of the beauty of these lands and waters and the care and expertise that's been given over millennia to look after them by the traditional owners. So I acknowledge all the lands that people might be joining on around Australia and other colonised areas, countries around the world. So before we get into our webinar today, we've got 2 really important announcements to make. Drum roll. We're launching today a new global network for tackling stigma in healthcare. So once we take these slides down, I'll put the connections in the chat for people who want to go and check this out. But this is an opportunity to bring together expertise from a range of different sectors. We ran a Tackling Stigma in Healthcare conference last year, and one of the big learnings from that was how excited people were to hear what's going on in sectors outside of their own. So we've got some funding for a couple of years to really do this, to curate information, resources, to profile people who are doing the hard yards as champions in tackling stigma. And we're going to do online events. We're going to have a monthly newsletter. We're going to run a conference. So please check this out, sign up for the newsletter, get involved, nominate someone you want to see, or yourself as a Tackling Stigma champion. So that's number 1 announcement. The second is building on our centre's aims to address stigma in lots of different ways. We've also run our first session of a short course on combating stigma, and a second one coming up in October. So again, I'll put the link in the chat so that you can think about this for yourself to extend your knowledge in theory and in application in the work that you do, or perhaps encourage people from your organisation to take this opportunity up as well. So there's our announcements and spruiking done. I'm going to hand over to Eleanor to introduce our amazing speakers for today.
Thank you. So today's session is focusing on patient work, inclusivity, labour and stigma. And we have 3 amazing guest speakers today. So we've got Christy Newman, who's a professor at the Centre for Social Research and Health and Deputy Dean Research for the Faculty of Arts, Design and Architecture. We've got Anthony Smith, who is a research fellow at the Centre for Social Research and Health and also a lecturer at the School of Population Health at Curtin University. And we also have our community respondent today, who is Nguyen, a public health professional with extensive experience across NGOs and government organisations, and who was also involved in the Stigma conference as well. So thanks so much. I will share the slides for today and I'll pass over to Christy.
Thank you, Eleanor and Carla. Can everybody hear me okay? I think that's probably good. Great. I'm joining from unceded Wadandi Budja saltwater country over in so-called Western Australia in the southwest in the Yallingup area. The name Yallingup, I've just discovered, is derived from Wadandi language also and means place of caves. I pay my respect to Wadandi elders past and present and acknowledge their sustained custodianship and care for this country, the country we see on the surface, and the country that is under our feet, holding more time and more knowledge than we can even imagine. If I'm going to ask who's holding the slides again? It's Eleanor, isn't it? Yeah, thank you. If you could do the next slide, please. Thank you. So yeah, thank you so much to the organisers for inviting us to come together to speak about this subject. I was really pleased to have the opportunity to think about some of the ideas in a paper that I wrote a number of years ago now, but which seemed to have resonated with a few people in terms of application to a number of different areas of health, and I've been working in. So yeah, it was really great to have this this chance. So I'm going to speak about inclusivity labour, and then Anthony is going to come and speak about a bit of that, but also patient work and how those two are connected or different. The paper that I've just put here is the one that I'll be speaking about. It was published in 2020, and I'll explain a bit about the background to that. But I just wanted to start by also saying, I guess in preparing for this, it's hard not to acknowledge just how profoundly the context has changed for exploring these ideas since this paper was published. And I think the next slide will make that clear. Well, at least it's probably a dramatic way to do that. In March of this year, Eleanor, if you could change the slide, the New York Times leaked this list of words which have been banned from official materials produced, published by agencies or programs funded by the US government, and you'll see inclusivity there on the list. It was quite shocking to see laid out so explicitly the areas of work, effort, attention that have really been mobilised over the last few decades, driven by civil rights movements of a range of kinds to address equity, diversity, inclusion, and participation of the broad populations that live in every society. And to see inclusivity on this list was a really interesting thing, because it's become a concept, I think, that we don't interrogate enough to really think about what are we talking about when we say something like inclusivity? What does that mean? What are we presuming? And so I am interested today in just taking a moment to think again about that, about why a concept like inclusivity has been increasingly accepted and increasingly applied, potentially not critically enough, but also with a real resonance, a real meaning for many people. So thank you again to the organisers for suggesting we come together to think about some of these ideas. It certainly feels timely. And so how did we get here? Why are concepts like this considered so threatening to people like Trump and other conservative leaders? So I've put this slide together just with a couple of images that came up when I Googled inclusive health. Now, I finished my PhD at the Centre for Social Research in Health in 2004, so just over 20 years ago. And in that time, we have seen an incredible mobilisation of attention to ideas around inclusivity in healthcare. And there's lots and lots of work on the definitions and histories behind that concept, and some of the others we've looked at that I've just flagged there. But in summary, just with this idea of inclusion, I will flag a couple of different elements of the meaning. Inclusion is largely intended to mean the act of making everyone feel welcome and supporting access to full opportunities to participate. Inclusivity is the state created through those acts, and particularly the feeling of being valued, respected, and welcomed. So both of these elements of that concept emerged from rights movements, which were challenging experiences of exclusion, rights movements driven around workers' rights, women's rights, the rights of racial minorities, people with disability in particular. HIV activism mobilised a huge amount of progress in challenging discriminatory health policy and practice, and as we know in this series in particular, recognising and trying to address and remake the conditions that were reproducing health stigma. And from the late 90s, we saw social inclusion emerging as a framework accepted, promoted by particular political groups, including UK Labour, and other areas in which the welfare state was being politically reimagined through concepts like inclusion. So, and I'll just also note, inclusive practice as a concept had a particular meaning in the context of disability activism, but was and has been increasingly applied to other areas, including the area that I have mainly worked in, which is gender and sexuality diversity. So as the concept of inclusion began to recruit more and more elements of social life into a framework for civil participation. The interest began to extend beyond just accessing healthcare, accessing, the care that you need as a kind of fundamental right, but also seeking to create conditions of belonging, of feeling welcomed and seen. And so we began to see real developments, I'd say, in the last 10 years or so in really long-standing activist work, which was challenging cultural systemic assumptions that health service users are by default presumed to be heterosexual, presumed to be cisgender, until shown otherwise. That was seen as a requisite, increasingly as a requirement in order to achieve that higher state of belonging, feeling welcomed. So again, I'm sure most people would know in the last few years, there's been a growing expectation that clinicians in certainly countries like Australia, higher income countries, were aware of LGBTQ people and had some training and understanding and preparation for knowing how to support them appropriately, even if uptake was really patchy. We also saw the development of health strategies for the first time in a number of states, which we've got here, and also at the national level for the first time. And yet, as inclusive healthcare began to be applied more broadly like this, it did feel like we were less often critically engaging with some of the ideas behind them. And there are many problematic dimensions of concepts like inclusion, even if that's unintended, if we're not thinking carefully about what we mean. One of my concerns has always been, excuse me, that the concept of inclusion typically imagines minority populations as located outside of a centre of society. So there is an expectation that people are being brought in, they're being included to enjoy the rights and benefits enjoyed by the mainstream. So the problem with this is that it presumes there is a centre to society that is normative, that is protected or different from diversity. And that's clearly not accurate. There is no inside and outside to society. Diversity is all through it. So I became interested in understanding the meanings communities were bringing to that process of seeking inclusive healthcare. Next slide, please. So I had an opportunity about 10 years ago when the ARC funded this wonderful project called Queer Generations, led by Emeritus Professor Peter Angleton here at the Centre for Social Research in Health. Now, I was invited to join as a researcher in that broader team to help with managing project data collection and writing some papers on topics related to my interest, which is largely health services, health cultures. The project was quite big. We interviewed 121 LGBTQ identified people who were born in either the 1970s or the 1990s. And they grew up, it was people who grew up in New South Wales, Victoria and WA, either in metropolitan or regional areas. There were 6 lenses applied to looking at the data. So I've just highlighted down the bottom there the lenses. Health and wellbeing was the one that I worked on mainly. And we've got a book coming out in a few months, actually, Queer Generations, and then it's organised around these different lenses. So there's a chapter in there on health, which extends on the work in that journal article that I was talking about today, but it's a bit more in-depth, which is great. So the project gave us an opportunity to think about what concepts like inclusive health look like if you think about that in terms of generational differences, to think about whether there has been changes, whether those meanings are consistent, whether the practices are shared or distinct. Next slide, please. So I'm not going to go through everything in this paper, but I just wanted to highlight a few key things. Health in this study was described as a domain of life that had provided some of the most difficult experiences that people discussed in this project. Participants were very clear, though, about what they wanted to feel when they were in health, when they in relation to health systems. They did want to feel valued, respected, and welcomed, in addition to accessing high quality care, that it was appropriate, that addressed their needs. So I wanted to think about the work that people were doing in order to achieve these experiences, because it looked to me, in thinking about differences across these generations, that there were some clear distinctions there, some real differences in how people thought about this, or talked about it at least. So I'll just also say there were consistencies. Both groups wanted, they spent a lot of time thinking about, or talking about, how they found supportive, safe clinics and clinicians, how they approached strategic disclosure of their own gender or sexuality in those spaces ahead of time or in real time, and I guess the energy, the time spent persisting in pursuing inclusive care experiences. So even if they found somebody that was, or had an experience that wasn't good, how they continued to turn up, how they continued to look for better experiences. There were real differences though. So people born in the 70s, like me, tended to be a bit more accepting of care being just good enough. Accepting that they might be tolerated by clinicians, and be kind of amusing to clinicians rather than accepted, welcomed, and celebrated. Yes, they tended not to talk about inclusive healthcare as a right, more as a nice surprise when you got it. So the 1990s born participants, in contrast, were keenly aware of their rights, and they were really finely tuned to identifying evidence of when providers were performing inclusivity to the standard that they wanted. So I've put here an example. There's two on the left. The first one is from a 70s born gay man who talks about the kind of slightly bewildered sense of, how the hell am I going to find somebody who is going to be able to give me the advice I need? And then how are they going to perform? What are they going to be like when I do? The 90s born group, it was a group interview at the bottom there, is a much clearer example of the expectations having increased in this population, in this set of participants. They really were disappointed and quite judgmental if a clinician wasn't ready to know how to respond appropriately if they've disclosed a non-normative gender or sexuality identity in that space. So both generations made clear that even if stigma is not explicit, and even if care is being provided in a way that is appropriate, they still know in an embodied sense whether or not inclusivity is being felt. And I think that's an important part of this piece. There were also differences that were not generational, that are much more systemic and structural. Barriers to gender affirming care was described as far more significant and discriminatory than other forms of health across the board. The book chapter goes into much more depth than the paper on that particular area. And certainly, of course, what we see happening right now in the US, the UK, and to a lesser extent here, but in certain parts of Australia, reminds us how fragile these systems of care are. So how easily concepts like inclusivity can be dismantled as the politics of the day evolves. So very briefly, just to conclude my part here, I think what this analysis helped me to understand, beyond the question of how communities learn to work within systems to secure the care that they desire, is that the domain of human health still relies on a massively oversimplified understanding of what it means to be human. And we still rely on communities to do the work of chipping away at that normative ideal, that normative core, trying to fit themselves into a form that will be read in order to access the care they want, or the care experiences they want, but ultimately then is not adequately rendering the true diversity of human lives and the true needs around human health. And I think this, for me, is why inclusivity is seen as dangerous, why it's on that list of banned words from Trump, not because it threatens the resource claims of those who don't want to share the imagined pie of healthcare resources. That's clearly part of it, but also because if you are supporting the inclusion of those who are different, it it contributes to that possibility that we are exposing the normative assumptions that sit at the heart of how we've designed health systems and other social systems. So gender, sexuality, embodiment, culture, what we are presuming to be the norm at the centre to which we are seeking to include others. And that is indeed a dangerous practice for the groups who benefit from those norms remaining unchanged. So thank you very much. There's a quick slide with acknowledgements there, and I'm going to hand over now to Anthony.
Great, thank you so much, Christy. I'll pass over to the next slide. I'm joining from Noongar Whadjuk Budja, here in Bawloo or Perth. So I'm going to be connecting some of those ideas about inclusivity labour a bit more explicitly to stigma and to this idea of patient work. So those ideas are all there in Christy's paper and work as well. So I'll just skip over to the next slide. So I'm going to be discussing the paper on the right. I've just put it in the chat, which was published earlier this year in Social Science and Medicine. And I'm drawing from the PRISM study, which is a big network led by the Kirby Institute, the Centre for Social Research and Health, the Ministry of Health, ACON, Positive Life New South Wales, and some other fantastic partners. And there's a pillar there looking at stigma. So this study was examining experiences of HIV and sexuality-related stigma amongst gay and bisexual men in New South Wales, including people living with HIV. And we focused the data collection on some priority populations of gay and bisexual men. So we interviewed 32 men, and this included young gay and bisexual men who are identified as a priority population in the New South Wales HIV strategy, and gay and bisexual men living in Greater Western Sydney and in regional and rural parts of New South Wales. So this analysis focused on understanding experiences of accessing healthcare and HIV services. And based on this analysis, we conceptualized participants' experiences through the concepts of patient work and inclusivity labour and stigma literature. So we'll just go to the next slide. So I want to draw together a few different concepts here. So when we look at the literature on stigma, a key component of stigma is that it involves managing others' negative social reactions to one's identity, as well as anticipated reactions. And there are enduring dilemmas about how to negotiate disclosure of one's identity or health status or practices, or whether to conceal those to avoid stigma from happening. If concealment is indeed possible, it's not possible in all situations or depending on the attribute that is stigmatized. If you're someone living with a stigmatized identity or attribute, there's a lot of work going on to manage those expectations and disclosure. So this idea of work comes up a lot in the stigma literature. Patient work is a sociological concept that originated from studies of people living with a chronic illness, and it comprises the often invisible forms of labour that everyone actually undertakes to manage health in personal and private contexts. So this can include medical tasks such as planning appointments, travelling to the clinic, managing your dosing of pills in the home. It can include biographical elements, so the ways in which your sense of health impacts your personal identity or your social role, and the emotional aspects of managing health or living with a chronic condition. And finally, inclusivity labour, as Christy has developed, describes the specific work that marginalised populations undertake when anticipating, accessing, and interpreting the practices of clinics and clinicians. So to extend on some of the examples Christy provided, it's that kind of work of having to educate your health provider about your specific health needs or your identity, looking for cues and signs that care is safe, and that could be rainbow flags, lanyards, posters. And taken together, these three different concepts point to cumulative forms of work, some of which everyone does as part of managing health. So everyone does some form of patient work, but there's extra layers of work that marginalised populations routinely undertake. Next slide, please, Eleanor. So I tried to conceptualize some of these differences in work, and I know this is quite a big slide, lots of words here, so I'll sort of work through different sections. In the top half, we've got what happens in the clinic. In the bottom half, we've got what happens outside the clinic. On the left side, we've got patient work. On the right side, we've got inclusivity labour, and then there's also a slither in the middle where there's crossover between patient work and inclusivity labour. So if we think about the top left sort of corner, we've got the sort of patient work occurring in the clinic. So, that's the act of actually visiting your health provider or being on telehealth, interpreting what they're saying, including medical terminology, forming a trusting relationship or a therapeutic alliance, and trying to figure out if they're going to take your diagnosis or symptoms seriously. Where that crosses over in the middle with inclusivity labour, there might be concerns about particular forms of judgment about you as a person or your practices or your health. If there is some kind of action or act that occurs that you think might have been stigma, you have to make sense of whether it even happened, and you might be thinking, were they trying to stigmatize me or judge me? And then there's that consideration of whether the provider manages your type of sort of specialist care. And then some of those more specific forms of inclusivity labour, so looking for the inclusive signage, determining if the provider is inclusive based on what they say and what they do with their body and their expression and so on. And on the basis of that, trying to figure out if it's safe or useful to your health to disclose your identity or practices in the consultation. Looking at the bottom left, when we look at patient work that occurs outside of the clinic, we've got the act of just needing to try and afford health costs or manage your finances around health, managing chronic illness if you're living with one, forming routines and habits that support your health, monitoring symptoms or the presence of symptoms, accessing medications and dosing them, planning appointments and travel, and managing health alongside everyday life, your family, your work role. So there's a lot of work that goes into being a healthy person. Then we've got where some of that crosses over with inclusivity labour. There might be anticipated stigma or other concerns about the provider that impacts you before you even attend the clinic. You might be sharing tips with peers about which GPs provide bulk billing or which GPs are inclusive. You might be delaying or avoiding care for particular reasons, including related to concerns about stigma or cost. And then those biographical or identity elements, the ways that health or your sense of identity might impact your sense of self. And then some of the more specific forms of inclusivity labour include that sort of cumulative minority stress, the burden of concealment and managing disclosure, and then specifically that work of figuring out if a provider is inclusive to your marginalised identity. So we will skip to the next slide. So I want to draw on a few quotes from our study. So again, we were focused on HIV and healthcare services amongst these participants. And participants in our study had varied perspectives about whether they thought a clinician should know their sexual orientation, their sexual practices, or their HIV status. So they tended to only think, the majority thought that a GP should only know about your sexuality if it was related to, for example, getting a HIV test or a sexual health screen. A lot of them were skeptical of sharing their or disclosing their sexual orientation otherwise. And I think this reflects the fact that we were speaking to some younger participants and also participants living in places like Greater Western Sydney or regional parts of New South Wales, where there was a bit less confidence that providers would be inclusive. So they discussed the anticipatory work, the effective labour, and the strategic decisions they made about disclosure. So I asked Hugh if he had ever felt like he'd been treated differently in healthcare, being a gay man. And it was interesting, he said that he thought he hadn't let himself be treated differently because he wouldn't disclose if he felt like the provider would sort of have that attitude. So As he said, there's definitely been times where I think I could have been treated differently, so I just don't say anything about my sexuality. And so Hugh and other participants pointed to the way that clinicians ask questions, their body language, and their overall confidence about asking key questions. And that could signal whether it was safe to disclose one's identity. Disclosure was also a site that could lead to stigmatizing encounters. So Gabrielle, who's living with HIV in Greater Western Sydney, would normally travel all the way to the inner city of Sydney to see his HIV health provider. However, he was quite ill and unable to drive very far with his illness. So he attended a local GP practice out of necessity, and he had written down his HIV status on the patient intake form. And when in the consultation, when he saw the GP kind of read on his form that he was living with HIV, he described this kind of shift in the consultation. So as he said, you could just tell he automatically shifted, like, get out. He was just very dismissive about what was going on. He didn't touch me. He didn't examine me or anything. He prescribed something and out the door. So there was this idea here that disclosure in the wrong context could actually be quite dangerous and could lead to stigma. Next slide. And so I also want to highlight this patient work, this effort. So you've got that effort going on in the clinic to decide whether to disclose, but there's also the effort of seeking the healthcare you need, in this case, seeking HIV prevention. So we had 4 participants in our sample report that they were seeking PrEP, and that PrEP prescription was in fact denied by a GP. And notably, these all occurred amongst participants living in Greater Western Sydney. So, and this is despite all GPs in Australia being permitted to prescribe PrEP. There's no specialist training required to prescribe this HIV prevention medicine. Chris's case here is interesting because he had been receiving PrEP previously from a doctor at an inner city clinic, and he was hoping to move all of his different prescriptions to one GP that was local, that was close to his house. So despite trying to advocate for himself with the GP, including explaining that she was permitted to prescribe PrEP, so he was very knowledgeable about the conditions under which PrEP can be prescribed. She refused to prescribe it, and he ended up basically unnecessarily compartmentalizing his care. So he had to travel an extra 20 minutes to go to a nearby sexual health clinic to get his PrEP, and then he was still seeing a local GP to get his other prescriptions. So participants in our study shared with us accounts of traveling further distances to access inclusive care, difficulties finding affordable and bulk billing clinics, especially in recent years as less and less clinics offer bulk billing, and the cumulative work of determining if these clinics were indeed safe. So just wanting to connect those ideas about inclusivity labour to these broader conditions about the work of accessing care that we all kind of do. We all want to have a low-cost local GP that can serve our health needs, and then there's these additional layers on top of that around your sense of identity. So I want to skip to the next slide. So in kind of rounding up this study and kind of connecting back to stigma, it was interesting that we found very few experiences of enacted stigma that participants described. So there were very few cases. Gabrielle's was sort of an exception, and there were only a couple like that. But what we heard from participants were significant forms of patient work and inclusivity labour routinely undertaken to avoid and to mitigate stigma. So while some of our other quantitative studies run by the Research Centre show that 1/4 of gay and bisexual men and about 30% of people living with HIV report a negative experience with a health provider in the last 12 months, those figures don't capture how these populations are routinely putting strategies into place to avoid these negative healthcare encounters happening in the first place. And that includes by traveling further distances to clinics, deciding to conceal one's status or practices, or just avoiding health services altogether. And that work of looking for inclusive providers. So patient work and inclusivity labour point to inequities in our health system, including cost, geographical barriers, the availability of fewer clinics or clinicians that provide inclusive services or that advertise that they provide inclusive services. So if we're wanting to seriously reduce stigma and improve health outcomes, healthcare services and systems need to better reciprocate all of this labour and work that that patients are putting into trying to access good quality healthcare. So there's an opportunity for all services to consider how they're making it clear that services and consultations are safe and welcoming, and for care to be affordable and with minimal access barriers. So over the next slides, I've just got some acknowledgements for the project and our funding and disclosure, but I'll finish there and hand over to Lup. Thank you.
And thanks, Christy. Can we please go to the next slide? I would like to also acknowledge the traditional owners and custodians of the lands that we're meeting on today. In my case, that's from Camaragal land. I pay my respects to elders past and present and extend my respects to Aboriginal and Torres Strait Islander peoples joining us today. I wanted to put up this screenshot I took from Witunga's Facebook page. The Witunga Health Network is based in the Kulin Nation, and I thought this was a really great diagram that is expanded further on their website around patient work and inclusivity labour, especially around reframing terminology like cultural load into cultural responsibility and colonial load. I thought this was a beautiful way in shifting the burden that is carried by health patients in systems where I know we use the word cultural load a lot or cultural barriers, but something to shift in our language and the power of language is that often it's not our cultures that become the load or the barriers, but it's actually the Western frameworks and colonial ways of working. So I just wanted to put that one there for food for thought. Can we go to the next slide? Thank you. So just to introduce myself, some of you probably already know me. It's nice to see a few familiar faces in the audience today. My name is Lup. It's spelled Loc, L-O-C, but I've started sharing with people that actually the Vietnamese pronunciation for my name is Lup. And I was kind of thinking about a lot of different people with Western names where we've learned to pronounce like names like Siobhan, for example. And I was like, why am I not introducing people by my actual name and using an Anglo way of pronouncing it? So my name is Lup. It's a Vietnamese name meaning fortune and blessing. The pronouns I use are she, her. Some of you have known me through the years working in the LGBT health sector, but today I've been welcomed to present here in response to Anthony and Christy's wonderful presentations. But I chose not to present from a professional or research academic background today, but I wanted to do something a bit more vulnerable and respond to the presentations through my own storytelling and photos, through my family photos, drawing on my personal experience of navigating patient work, in particular in relation to accessing gender affirming care as a trans woman. Can we go to the next slide, please? Thank you. So these are a few photos of me and my family since I was a kid. So I grew up as a young queer and trans kid in Cabramatta in Western Sydney, raised in a Vietnamese refugee family. And from about the age of 4, I knew that there was something different about me and that there was this like inner girlhood and femininity that was like screaming to come out, and which you can really see in the photos. I'm the kid on the right-hand side in all of those photos actually, which is a coincidence. But ever since I was a kid, I always had this like little urge to like do this little curtsy thing with my foot, which you can see in all the photos. And it was like my way of like trying to be really feminine and girly whenever my parents pulled the Kodak camera out. And my parents would always be like, put that foot down, what are you doing? But basically, my parents from a young age saw that femininity in me too. But it was something that was often shut down, ignored, silenced, and sometimes it would actually it would have taken them my whole lifetime before they would fully accept me, and only finally affirming my transness and womanhood in, I would say, the last 2 years or so. For most of my life, My queerness has been something brushed aside, left unspoken, and at times deeply shamed by family and the community around me. And there were periods where my dad also didn't talk to me because of it. And I was actually kicked out of home at the age of 18 because of it as well. But over the years, I tried having these conversations with family about my transness, but it never quite landed because so much of the language and frameworks that we use to talk about trans identities and what I had access to were so rooted in Western ways of talking about gender and sexuality. And these didn't really connect or resonate with my parents' understanding. There were no transgender stories or reference points in media that I could turn to and point to and connect them to my parents culturally. Can we go to the next slide? And so you can imagine how this sense of shame and lack of family and cultural support and stigma would have become a barrier to me to even think about starting on getting medical treatment and hormones. And it actually was a major reason for me in delaying my gender affirming care until later in my 20s. But over time, my dad was able to spend his personal time connecting with friends from Asian communities in his background and around his age who had queer family members. And I didn't know this until years later, but he actually spent a lot of time connecting with them, hearing their stories, and connecting culturally, which opened him up to be able to have those conversations with me. And that's a photo of me when I was 4 with my dad. Can we go to the next slide? So around my neck, I wear this necklace, which has a jade of Wang She's in Vietnamese, she's known as Wang but in Chinese, you might know her as Guan Yin. She's a bodhisattva for compassion. And this necklace was actually passed down from my grandparents to my mum, who gave it to me. And when my mum was struggling to understand my transness, I lent on this imagery in Buddhism to connect my mum to understand my transness a bit more. And I had this conversation with her where I was like, you know, Wang how when she was represented in Tibetan and Indian Buddhism, she was represented as a man. And as Buddhism moved to the East and went to China and Vietnam, her representation turned into a woman. And I was like, well, that's kind of like me. And it was actually a breakthrough moment where something shifted in her and her heart began to open with curiosity and understanding because my transness was rooted in something that was deeply connected to her culturally and spiritually. And can we go to the next slide? So early last year, I had this really beautiful moment with my parents where they actually expressed their support for me to go on hormones. And to this day, they've been like the biggest supporters and advocates for myself, and they've really helped me gain that confidence to really embrace my transness within family and within culture. So the labor of navigating stigma, or the reason I wanted to share this story is I wanted to start by saying that the labor of navigating stigma in healthcare and the medical journey, it actually started for me personally decades before I ever entered the health system as an adult through the family. And the family actually was an indirect aspect of the patient work because it was an area that I had to work with over years to actually build that allyship and care amongst my families before I felt confident to go to access hormones. And that on the right-hand side is actually a photo of my dad when I was visiting him in Vietnam. And he was like, oh, let me take you to this bubble tea place that I've been going to. And he drove me to this bubble tea place and it had this rainbow flag. And he was like so proud of himself that he's been supporting this rainbow business. Can we go to the next slide? The next thing I wanted to share is the importance of peer networks and information sharing. So part of my personal patient work involves relying on peer networks and friendship circles to build my personal knowledge and confidence around accessing gender affirming care. And I actually spent many years on and off reaching out to trans girlfriends, reading forums, asking questions like, which doctors do you go to? Are they affirming? What's your hormone dosing like? What changes have you noticed? Any issues? What are the physical, emotional impacts that you've had? Do you feel happy on your hormones? And here are a few screenshots of those online conversations I had with the permission of my friends. And it was through this peer learning that I found that safety. I was able to find providers who had been vetted for by my friends. Like it was easy to look things up online, but to actually have another peer actually vet a service was so important for me, to truly know if that service was affirming, accessible, free from the risks of stigma. And that knowledge passed from one trans person to another really became a lifeline. And you can see in these screenshots here, like the topics that are covered in these peer conversations can be about which doctor they're seeing, the dosage that they're on, and what impacts and changes they've noticed. But you can also see in the last one there, like emotional support was a major positive impact from this peer network. And something that I had said almost a year ago now is like, thank you all for your advice and helping me get here. I've been feeling so up and down getting to this point with both fears and excitement. But now that I know that I'm on it, I know this is exactly where I needed to be. And friends just really providing that support and sharing their own emotional journeys as well. Can we go to the next slide? So here's a photo of like the first ever box of estrogen I received last year, and a really ugly candid photo of myself that my boyfriend took as I was taking my first pill. But navigating health services as a trans woman, it has been a journey marked by both affirming care and painful setbacks. And years ago, I went to a clinic and I asked them to change my gender marker in the electronic records. And the admin worker working there at the time gave me a response that was a flat out like, no, we can't do that. Without any explanation, no empathy, no effort to affirm me. And I never returned to that service. And that moment really stayed with me because it was not just the administrative barrier that really affected me, but it was that unaffirming experience of being dismissed so casually. But I've also had experiences with clinicians that have been deeply affirming, and clinicians who affirmed my gender spoke about my body with respect, who asked questions with curiosity and care, and found creative ways to work around the system limitations. For example, I had a doctor who couldn't change my gender marker in the system, but they would manually get a pen and actually crossed out my gender, like the sex assigned at birth, on all of my referral letters and pathology labels that were printed out. And they would explain to me why they did it and made sure I felt seen. And also explain to me when I would still expect to see misgendering happen in the system, which for me personally, even though it's not the best, it's still great because it kept me informed and prepared for those moments. And this helped a lot in reducing the load I had to do personally around patient work. There have also been moments in my healthcare journey where mistakes were made, like being misgendered during appointments or in referral letters, and even after I had clearly identified my gender information during intake. And these moments were deeply painful for myself as a trans person. But in these moments, I often was faced with a choice, and sometimes I made the choice to walk away because that emotional burden was too much. But at other times, I actually had to be more thoughtful in my approach, and I actually reflected, is this the clinician's intent? Are they asking, I had to ask myself, were they making this mistake stems from ignorance and harm, or did they genuinely care and have their heart in the right place, but just made an unintentional slip? And in those moments, I saw an opportunity to safely address the issue and respectfully help correct it. And this kind of emotional labor, navigating stigma, correcting misgendering, educating providers, it can be exhausting for trans people, let alone actually navigating the health issue as to why you're presenting in the service to begin with. But when I've approached these situations with compassion and clarity, I've seen them as opportunities for repair between me and the clinician. And I've had clinicians who, after being corrected and took accountability and listened deeply, committed to improving their practice. And so something that I learned is that these moments of repair have led to some of the most affirming healthcare experiences I've had, where trust was built and the therapeutic relationship was a space of mutual respect, compassion, trust, and shared learning. But getting to that point required practice, where I myself had to learn to be confident by practicing advocating for myself. I myself also acknowledge that I've worked in the health sector for many years, so talking about these issues becomes really easier for me. And it also relies on both myself and a clinician to enter the relationship with goodwill as well. I know that that dynamic isn't always going to be there. But something that I've learned is, yes, patient work can be work, but it can also lead to really positive results with the right clinicians as well. Can we go to the next slide? And so just some key reflections on addressing the impacts of stigma on patient work. As I reflected on my journey, both personally and professionally, I wanted to share some insights into how we can continue to address the impacts of stigma on patient work, especially by looking at these three social pillars. The first one being the family, community, and culture. For many of us, stigma begins at home, in our childhood and in our youth. Families and communities are often the first environments where shame and silence are sown into our lives, but they can also become powerful sites for healing. And we need to continue investing in stigma messaging programs and campaigns that speak directly to communities of culture and faith, resources that are culturally safe, spiritually resonant, developed by and for community. And while we are doing this work to address stigma, especially around topics like gender and sexuality, HIV stigma, LGBT communities, we need to also be conscious of not perpetuating other forms of stigma, such as racism and racialization, and referring back to that colonial load and Western framework load that I showed at the start. Like, there's something that I hear a lot about sometimes in the sector, that we can use language in a not best way, which is around cultural barriers that multicultural communities can face to access LGBTQ information. But I think the thing that we need to be flipping the script is reflecting on the systemic barriers and what barriers are we creating that are leaving people out from the conversation. Peer networks have also been a long cornerstone of community care. They're where we share health knowledge, build confidence, and find safety. Our sector has known this for years, but we must continue investing in peer networks that evolves with how people connect. And this means expanding innovative models to include like digital platforms that people are using, whether it's across young people, how cold and migrant communities might use social media differently, trans people as well. But something I've noticed in my work is the importance of maintaining accessible formats like text messages, phone calls, newsletters. And I've seen that a lot, especially with older queer people as well, who really want to stay in the loop through these more traditional forms of technology. So it's important for us to not create further inequities by potentially leaving people out from information access. And the doctor-patient relationship, at the heart of inclusive healthcare is the doctor-patient relationship. And research tells us that this relationship is built on mutual knowledge, trust, loyalty, and regard. And for trans people, these elements need to be actively cultivated. So when we look at mutual knowledge, it means understanding the patient's lived experience and health needs, including trauma and stigma, and how they might carry that into the clinic, which we saw in Anthony and Christy's presentations. And trust is built when the patients feel the clinician is competent, knowledgeable of their needs, affirming and committed to their health and well-being. Loyalty referring to the patient's willingness to forgive a clinician for their mistakes, while it's also the doctor's responsibility to have a commitment to not abandoning the patient and continually improving their practice. And regard, meaning that the patient feels seen, respected, and supported, and that the doctor is truly an ally and someone on their side. So just a closing thought for myself is reducing stigma in patient work is a collective responsibility that crosses health systems, communities, and cultures. When we build care that is inclusive, compassionate, and culturally connected, it's not just about improving health outcomes and equity, it's about restoring people's dignity within the health system. Thank you, everyone.
Thanks so much, all three of you, Christy, Anthony. Just what a wonderful dance between the research and the personal. And in the chat, you'll see a lot of love for all three of you and your work and your ability to share such amazing concepts and experiences, and people reflecting on their own experiences as well. I wondered, Christy and Anthony, you've had a chance to have a look at the chat, if there are any themes that you want to address while Lap's catching up with what's in the chat. We've got a few minutes left. Christy or Anthony, anything you want to speak to?
No, excuse me. No, I guess I mean, my first thing I was reflecting on is I just love that so many people in this seminar are coming from really different places in which they work and think and live these issues. And I think that speaks to the importance of not siloing some of these kinds of concepts. They really do apply and differ depending on the context. So yeah, I love reading that. Thanks everybody for being so generous in your comments.
Anthony, anything you reflecting on?
Yeah, I just wanted to reflect on Bridget's point there about the deciding to conceal as an active construction. Yeah, I agree. It's a tension in describing that work. That for some people it is a much more mundane thing where they may be going to a health encounter, not necessarily planning to disclose or that disclosure would be important, but it might come up or it might not. But for other people, it's a much more planned, active, agential kind of thing. But that question about the agency as well, one of the reasons I really like inclusivity, labour and patient work was to kind of move away from just thinking about barriers to care, which I think sometimes flattens the experience or doesn't really give much agency to what people do in their lives. And I think the advantage of paying attention to the work that our communities are always doing is that it does point to the sort of agency that people have within a constrained system, where they're facing up against health services and trying to figure out what care works for them. And I think it points to the work that they're already doing that could be supported in a lot of different ways, including through peer networks or including through the health systems kind of meeting them halfway.
Thanks, Anthony. There is a question there from Jordan, but love anything you want to say before we get to that, and then I'll come back to you, Christy.
Sure.
I think there was one comment by Lawrence, just even around like terminology that we use, like even trans. Like I think like my parents didn't understand what that meant, but if I just broke down to simple words like saying, oh, someone who used to be a boy and is now a girl. And I think sometimes we might not find that the most affirming language when we look at using Western medical frameworks and talking about transness. I know that just breaking it down simply like that was a great way in just like getting on the same page with parents. But I also just wanted to give a shout out to Rochelle as well for sharing their experience as a non-binary person with breast cancer and the work that they're doing in bringing that trans inclusion into the space. So thanks, Michelle.
Christy, back to you.
Sorry, yeah. Look, on Jordan's point, which is about I guess a moment that we are in currently, since COVID in particular, of thinking about that point of intersection between activism around inclusion as it pertains to people with disability and other health vulnerabilities, and really the rapid way in which we saw whole populations engage with masking, distancing, air filtering, and so on was kind of this incredible opportunity to look at harm reduction histories as they were kind of evolving in rapid form. And it is, personally, I'm finding it really difficult to know how to make sense of how rapidly that's been abandoned in so many contexts and how new forms of stigma are being produced around people who do mask in certain places or the ways in which different spaces are being felt to be safe or not for different groups. So yeah, thank you for the comment. I'm not sure that I've got particularly useful advice except to say that I think it's a really important one to be looking at, particularly around, yes, how are healthcare settings or other settings being made genuinely inclusive through the range of forms of harm reduction that we know are going to be needed to make them accessible. Yeah, it's a distressing and important moment to bring our full curiosity and politics to.
This has just been such a fantastic conversation. We'll wrap up now because we only have a minute left. Really think people should go and have a look at these amazing papers. that Christy and Anthony have published. There's a couple of other ideas there, I think one from Ivan as well. And think about, listen, remembering Lup's words about navigating the world from your experience, Lup. Just a fantastic bringing together of these ideas and the genuine experiences of people. So thank you everybody again for being such an amazing community to talk through these complicated ideas. And we look forward to the next spotlight, which is going to be at the end of September. So you'll see advertising about that in a little.
And just to end on a positive note, but to echo what Bridget said, Lup, the photo was absolutely beautiful, not an ugly candid at all, and everyone loved your nails.
Thanks everyone for today.
Thanks everyone.
Perfect ending.
Bye.